All right. Okay, I think we can go ahead and get started. So, once again, thank each and every one of you for joining today's coffee and conversation on pregnant and surviving maternal health in the Black community. Today's conversation is going to be centered on the unique experiences of Black birthing people. We will discuss the intersections of domestic violence and birthing, as well as ways to better support Black pregnant survivors. I am joined here today by a special guest. Her name is Tahira Henderson, and she's coming to us from Mamatoto Village, and she'll talk a little bit more about what she does. But before we get into that, my name is Araba Eduapau. I'm the Senior Research Specialist at Ujima Inc. And I just want to welcome each and every one of you. This is one of the many parts of our Domestic Violence Awareness Month series. And so we are super excited that you have chosen to join here today. Tahira Henderson is a perinatal community health worker at Mamatoto Village, Inc. She provides culturally sensitive care, education, and support to birthing families in the DMV through the Mothers Rising program. She conducts home visits, attends prenatal health appointments, and assists families with gaining access to resources and social support. Tahira received a BA in psychology from Spelman College. She has years of experience as a community health educator. Her love of service began in high school when she volunteered with Metro Teen AIDS. She later went on to serve as a volunteer with the U.S. Peace Corps, where she worked in Kenya as an HIV/AIDS educator. She also volunteered with the American Red Cross as an emergency response volunteer. Tahira currently focuses on Black maternal health and reproductive justice as a full spectrum doula. Tahira, welcome.
Thank you so much.
Thank
Glad
you.
to be here.
Yes. So can you tell us, what is Mamatoto Village? And also, could you talk a little bit more about the Mothers Rising program?
Sure. So Mamatoto Village is a nonprofit organization that focuses on perinatal maternal health care here in the district. It's been here for 10 years. We're just celebrating our 10-year anniversary. It is an organization that was created by two Black women, and culturally sensitive care is the whole impetus for Mamatoto Village. So it is created with our community, with Black women in mind. We service everyone, but the model of healthcare is very specific to the needs of the African American community. So it's a three-generational model. And so we know that birthing people don't exist in a vacuum. If we're servicing primarily people who identify as mothers, then they can't have problems with their children or people in the household and think that we're taking care of their needs. We need to take care of the family in order to take care of our primary client, which is the birthing person. They don't exist alone. And so that model is unique from some of the other maternal health service agencies in the country. We're really focusing on the needs of African Americans, primarily urban African Americans, and developing this model of care really helps to kind of narrow down the issues of how the Black maternal health crisis is different than the national crisis. Both are happening simultaneously, but we know the impact on Black women is different. And there are several reasons why our experience is unique. And so we really work to address that.
That's actually a perfect segue into the next question. I wanted you to talk a little bit about why it's important for us to talk about how race impacts birthing people's experiences.
One reason, we now have a better sense of the data. And initially the thought was, oh, maybe it's a socioeconomic issue. If we improve the living conditions or the economic status of African American women, then their health outcomes will be different. We know that's not the case. Upper middle class, wealthy Black women are having birth experiences that are similar to some of the poorest white women in rural areas, and that doesn't make sense in terms of resources and all that we know about accessing healthcare in the U.S. And so it points to a bigger problem. And now that we're seeing more of the research, the concept of weathering, which was really eye-opening for me when I started training at Mamatoto Village. And for those who may not be familiar, it's the concept of how race and stress impacts your health, and how it can have direct outcomes where your chronological age, it actually ages you. We're finding that the health impact is that of someone of advanced maternal age because of the stress of racism. And it impacts your heart, it impacts your blood pressure. And these are things that aren't related to just your health and how you present, but actually the trauma of not being believed when you go to the doctor, of having to code switch and having to constantly think about, do I appear angry? Do I appear aggressive? Can I express myself, clearly when I'm in pain? How am I being perceived? And the stress of that impacts communication with providers, and it impacts the services that we receive.
Wow, that's good. I think I'm learning things I've never heard before, like that the
Right.
whole being aged because
Mhm.
of the racism and the stress that we as Black women undergo. So thank you for that. And you touched on a really important point, and you mentioned something about socioeconomic status not being a protective factor.
Right.
We've seen examples of this in modern day time, right? Like when Beyonce gave birth to her twins, I think she suffered from preeclampsia. Serena Williams as well, she was not listened to by the doctors. And so I think that's just you're pretty much affirming what we've seen in modern day. So thank you for touching on those important points. With all this being said, how do you combat systemic barriers during the birthing process? Like in your work and what you do, how have you specifically been able to address these barriers?
So the work has been really exciting because it's sometimes it seems like the problem is so big that it seems hopeless. And then when you step into this space and you have a model that really addresses the care needs of African American, you see the difference that you can make. So education and health literacy, a lot of times most of us, before you're a birthing person, you may see the doctor once a year if you're a healthy person. If you've never experienced any kind of serious illness, your communication with your provider may be limited. Like unless there's a problem, you go in, you get checked out, but you're not having regular dialogue with a provider that starts monthly, then becomes biweekly, then becomes weekly. This is the most you've ever spoken to a healthcare provider in your life. And being able to be an active participant in your health may be a new concept. So being able to educate people about what their rights are, what they can expect, and that this isn't just a top-down process where an expert is telling you what to do. If something doesn't work for you, being able to communicate that the reasons why you're making your decisions makes it a collaborative process. And then we can advocate better because that person is empowered. So it's not necessarily um, coming in and protecting our client. Certainly we can step into those roles as advocates, but it's empowering that person to make decisions for their own health, and then in turn make decisions for their family, for their health, education. It really trickles into all other aspects of society and care. So starting um, with the birthing person in the beginning of their family trickles into empowerment for the whole family.
I love that you talked about empowerment and how important that is, especially for the birthing person
Right.
to be able to have, right, during the whole experience and process. And that helps them to speak up for themselves.
Absolutely.
And I think you kind of answered my question, which was going to ask about self-advocacy and what does that look like.
Mhm.
But I guess what I can ask you is, why do you think that some birthing people are not empowered to speak up for themselves? What are some barriers that you've seen that kind of prevents them from doing that in the process? And how might their voice might be like stifled?
Stifled, sure. So sometimes it is because this situation is so foreign and they don't know what to expect when they're going in. There is that white coat syndrome of being kind of intimidated in the process, and having someone speak to you and you're not being heard. Sometimes there are language differences. For instance, when they're doing screenings for preeclampsia, we're looking for swelling, dizziness. if they say, oh, I feel shaky or I feel woozy, sometimes that gets missed. And so, in a very brief conversation with a provider, maybe that provider is spending 10 minutes, as opposed to when we go into the house and we're spending an hour and a half talking to that person about what they've been experiencing, how they're feeling. We kind of help them with that communication. So sometimes it's a communication issue. Sometimes it's assumptions made by the provider, based on age, socioeconomic status, assumptions about how they present and what their family life must be like. And so they're making recommendations on assumptions and not the reality of the client or the patient and what they need. Um, Sometimes when they give that pain scale of 1 to 10, and the way you answer that question, sometimes someone may say 10, I need medicine, I'm in pain. And they say, you're not crying, you're not a 10. And so then they dismiss you at that point. And so the way you answer that question triggers something in that provider's mind about what they believe about you and how they address you and what your needs are. And also there is the racist history in medicine of Black people being of thicker skin and not having the same needs for pain medication. That misinformation was still in medical textbooks up until the 90s. And so a lot of providers got that information. And even if they're hearing that that is incorrect, that still was a big part of their training experience. And we know that there's a gap between current research and active practice. And so the more that we push and the more that we educate, we are bringing everyone along with us to make that change.
That's good. Yeah. So as I'm hearing you, I think one thing that many advocates who are joined in on this call today can benefit from is being aware of some basic patient rights. So what are some basic patient rights that folks aren't aware of and need to be made aware of?
Sure. So informed consent, being informed of all of your choices with any kind of medication option, any kind of medical procedures. We use an acronym BRAIN: benefits, risks,
I
uh,
love that.
benefits, risks, alternative. What does your intuition tell you? And if I do nothing, what will happen? And so you always have choices, unless it's a life or death emergency and we need to move this instant. There, you have the right to be informed of all of your choices and how those choices will impact you. So that's number one. Number two, which is a big thing that a lot of birthing people don't know about, medical rape is a real thing of being touched without giving consent to do that. Cervical exams that aren't necessary, or you believe that you have to have or you can't say no to, that people have a right to your body at any point through the birthing process, and that's not true.
Mm.
So your right to bodily autonomy doesn't end because you're giving birth. And a lot of times it's like, oh, well, I'm in labor. This is a unique experience. I didn't know what to do. They did these things to me. I didn't understand what was going on. It was painful for me, but I didn't feel like I had any choice. And you do. You do have choices. You do have the right to understand what's happening. You do have the right to understand why this is medically necessary, if it is medically necessary, and what your options are at any point. And so that's a huge part of the birthing process for advocates, and how really abuse happens to Black women in the birthing spaces. We saw a lot of that, unfortunately, with COVID, because birthing people were isolated. Because of COVID policies, you couldn't have family in the space with you. You couldn't necessarily have doulas in the height of COVID with you. And so it was you and a whole host of people coming in, and it can be a very overwhelming experience, and you may not feel comfortable in advocating for yourself, or may not be in a space to do that.
Thank you for amplifying the importance of autonomy
Mhm.
and maintaining your autonomy even through the birthing experience and process, because I think, you would think it's something that's self-explanatory, but it's not, right? Because
Yeah.
like you said, it's such a unique experience. And I think it may be a time where you're not really sure what rights you have, even if that means the rights to your own body. So I'm so
Mhm.
glad you were able to emphasize that. Now I kind of want to pivot a little bit and kind of bring in this experience of domestic violence that many birthing people experience. I think that's important for us to get into today. And so my question to you is, and feel free to draw from experiences in your everyday work, but how do you identify signs of domestic violence during home visits or other interactions? And how do you respond?
So, first, just the statistic of for Black birthing people, one of the number one causes of maternal mortality and one of the number one risk factors is domestic violence. So it's a huge health issue. It's a health crisis for birthing people, especially for Black women. And we are mandated reporters, and there's certain entry points in the community where you may be the first to witness domestic violence. And certainly we are one of those entry points doing the home visits, but also your provider is. But I was just thinking, and many of you have had this experience, you go to the doctor and there's a checklist that and somebody is doing an intake, they may be doing your vitals, and they ask you if you've experienced domestic violence. They're looking at their computer screen, they're not even looking at you, and they're going down a list. You've just given your weight, you may not even feel comfortable answering that question, and then they're asking you very intimate details of your personal life and expect you to answer honestly when you may or may not feel comfortable or safe to do so. And in the home visit space, we're looking at them in their eye. We're having a much longer conversation with them before we get to very intimate details. And we're starting where they feel comfortable. So many of you, if you work in domestic violence spaces, you know there's levels of readiness to address domestic violence, readiness to leave. And so once we see signs of just a general lack of safety, we're making plans for how they're going to deliver their baby and how their needs are going to be met. And so one of those things is family support, is security in their own home. And if there's risks presented from domestic violence, whether that's physical abuse, whether that's financial abuse, because a lot of times you are taking maternity leave, you are vulnerable physically, you're vulnerable financially, you're vulnerable emotionally. Your dynamic in your relationship may change where your partner may have been the most important person in your life, and then you become pregnant and there's a shift. And that shift can upset things and increase your risk for violence. And so we're seeing these things in the home, and they may not be ready to say, oh, this is abuse, I'm ready to leave. But we know that this is an issue and it's a threat to their safety. So let's make a plan. So we always create a safety plan and discuss what that client's risk factors are, where they are, and what resources are available, and give them options. If you're not ready to take this step, let's talk about counseling. Let's talk about how you can make yourself more secure financially, or what safety mechanisms we can put in place that make you comfortable right now. So we create a collaborative plan with our clients, and that's our first step to address domestic violence. We're not forcing them to do anything. We're just creating a support system for them, and
I
it
love,
may grow and shift as their readiness changes.
yeah, I love that. I love collaborative plans. So it's also giving them the power to choose, and you're being a support system. That's great. Now, the next question, and this may go into a little bit of some work you've done
Yeah.
in the past, but we know that for abusive people, exposing their partner to HIV, AIDS, and other STIs can be a tool of power and control. In
Mhm.
what ways did you personally see this during your time with the Peace Corps and the American Red Cross?
So it's interesting. So initially, when I was working in the Peace Corps, and I worked in the Peace Corps in Kenya from 2003 to 2005, and I worked with a group of commercial sex workers who it was called the Solidarity of Women in Distress, who were actually going around community and spreading HIV/AIDS prevention information to other members of the community, and so it really gave them a position of empowerment where maybe they were looked down upon in their community, but it gave them a place of pride and importance in their community, and they were a trusted source, even if they were frowned upon in other aspects. People knew that they knew what they were talking about if they were giving sex ed education. So it was a very interesting thing. But a lot of the time, the assumptions about long-term relationships or marriage, and that being a protective factor from STIs. And we don't need to discuss those things, or we don't want to shake things up with a long-term partner, can make you more vulnerable. And so certainly the power shift, I see it now with our clients when they're doing standard screenings, or when they're feeling that something is wrong, but really being afraid to address the root of the problem. And depending on where they are in their pregnancy, the health risks that can come with having STIs or frequent STIs, because they they are getting treated and their partner is not, and the communication with the partner and the safety to communicate, you need to be treated as well. You need to make changes. We may be able to make changes with them, but they're not living alone. They're not being treated. They shouldn't be treated in a vacuum, but there may be a break in communication. And so that definitely has been a theme in the work that I've done over actually 20 years, which is really interesting that you brought up that question. It really did make me smile. Um, Domestic violence and maternal health are community issues. You start with, you know, the client, the patient, the person, and it spreads out to the family, and it spreads out to the community to support. You cannot make an impact if you're not affecting the family, if you're not bringing the family into it, and you're not bringing the community in to support the people who are having that experience.
Thank you. Thank you for that. I wanted to draw in another angle to this conversation, and it's about plus size women and their birthing experience.
Mhm.
Can you talk about some misconceptions surrounding plus size women and their birthing experience, and how, I guess, in your work, have you addressed barriers specific to people in the plus size community?
So there's a huge, and it's that fat phobia is one of the last acceptable forms of discrimination and abuse that often gets overlooked. A lot of times the assumptions about larger women's pain is a huge issue, and that they can, for some reason, take more pain than smaller people. It's insane. I see that all the time in health spaces. Um, Sometimes providers don't want to give as much support if they're under anesthesia, because maybe moving their bodies or manipulating their bodies. They may be rougher with larger bodies. There's also a disconnect because um, patients have been discriminated against in the past, and so they don't feel comfortable having conversations with the providers because they always take it right back to their weight. They will express a real issue that has nothing to do with their weight or eating, and providers bring it right back to, oh, you have preeclampsia because your BMI is this. They will constantly focus on the BMI and ignore all of the other issues that the patients, the clients present. And so, number one, helping to provide the education that these are your issues, these, being comfortable and being empowered to stand in, no, this is my issue. It's not my weight, or that's a secondary issue. What I'm presenting with is important and it needs to be addressed. And Also the presence of someone else to kind of remind whoever is providing care that, wait, this isn't the standard of care that everyone should be receiving. And respect is always important. And so being able to mirror and support that with providers is definitely necessary, and it's a big thing that I encounter with some of our clients who experience the world in a larger body.
Yeah, thank you for kind of explaining that to us. I think if you're like me, I was very unaware of how the healthcare system, even in their treatment of how they're
Mhm.
handling plus size women, could be rougher,
Mhm.
and that preconceived notion of if you're bigger, you may be able to handle more. Like I wasn't even aware of that. So thank you
Yeah.
for educating us on.
I once heard a provider say to about a patient, she's not a delicate flower. What's that supposed to mean? Like, I mean,
Wait
it
a
really can
minute.
be infuriating.
Wow.
They're
Yeah.
talking to you about their pain and, oh, she's not a delicate flower.
Mm.
Like things like that. It really is shocking and in real time. I can't believe you said that out loud.
Ooh, that is heavy. That is super heavy. And this work is heavy,
Yeah.
period. Right? You're on a daily basis, you are combating medicalized racism and systemic barriers within the healthcare system. You are facing the everyday realities of the maternal health crisis in the US. You are identifying potential signs of domestic violence. This is a heavy work. So, how do you and other advocates decompress from this work, right? What are some methods? What are some strategies to still engage in this work, but also take time to kind of recuperate and make sure you're
Mm.
taking care of you?
It can be heavy work. Certainly, there is a sense of sisterhood where we work, and so there is a lot of camaraderie and laughter. Also, with the patient, it can't always be about struggle, and even for their own health, it needs to be about joy. And so, participating in that process and regularly reminding them and participating in that with them. Sometimes it's like, hey, let's have our meeting at a lunch spot. Let's go to lunch. You haven't been out to lunch. I haven't been out to lunch. Let's do that. Let's talk about these things there, or let's make this space joyous and play some music in the birthing room and really make this a party. Um, so certainly the camaraderie. We advocate for our clients to receive mental health support. Anyone who's providing these services also should seek mental health support. That is um, a big thing with service providers is taking their own advice and certainly seeking mental health support, seeking solace with like-minded people. Finding joy, having retreats and times that are not about work, tuning out and just having fun is so important for creating a healthy balance. Um, because sometimes you do have to go in kind of ready to fight, and that is a stressful thing. And so, as much as you are fighting and arguing, you also need to be creating intentional about creating moments of joy and celebration.
I love that. I love that. I'm going to take some tidbits from that and apply it in my own life. So I wanted to talk a little bit about some super vulnerable populations, like marginalizations within marginalizations, right? We've talked about the experience of birthing people, but we haven't really specified what is your experience with teen mothers,
Mhm.
mothers who may be neurodivergent. What have you seen, and how do you advise that they advocate for themselves? What are some support systems that can be offered to teen expectant birthing people and those who are neurodivergent or with
So
disabilities?
right, and it does matter, and I experience both, and they are unique challenges, and sometimes they often they can coexist together. Um, so first of all, in the district as a birthing person, so you're a child, right? You're being treated through the healthcare system, and you're not, and your parents are very much a part of your decision making process until you become a birthing person, and then as an expected mother, you are now the guardian of care. You're the care provider for yourself and your baby. And so that shift um, can a lot of teen moms are just not prepared for that. Like now you are in charge, you are the decision maker, and they may not be fully aware of what that means and their rights. And so being informed of their rights, number one, is huge because it is different than any other experience they've had thus far. And we're a lot of us have our first experiences with a gynecologist if we haven't been sexually active before, or we haven't been treated by the health community as someone who is sexually active, those first experiences come at around 18. And so you may not have been to the gynecologist before, but now you're a birthing person and you're regularly seeing a gynecologist. And that is a shift, and that can be intimidating. And so, what does this mean? What are my rights? Bodily autonomy, really understanding and being able to have conversations and speak for yourself. um, it may be a new thing for them. And so really taking the time to make sure that they fully understand. And this is also true for neurodivergent clients, making sure that they fully understand what's going on, and sometimes creating some space to make a decision. Because sometimes with lots of lights, lots of sounds. If you go into the hospital and there may be 4 or 5 people in the room. And so it may be very overwhelming and intimidating to even try to process the information that is presented. And so, as an advocate, trying to create some of that space and understand what their process is for understanding information, and trying to getting that understanding outside of the medical space so that you have a plan to enter the medical space is really important, making sure that they understand what they're signing. A lot of times, you put a stack of paperwork in front of someone, and if there is some discomfort with reading or understanding, it's like, let me just go ahead and sign this to kind of get this anxiety producing packet out of my face. And you don't know what you've signed, you don't know what you've agreed to, you don't know what's about to happen. And so, again, a lot of times, if it's not a life or death emergency, there is time. And so, making sure that the client understands that, and that we're creating space so that they really feel comfortable through the entire process and they understand what's happening, is huge.
Yeah, that's good. That's good. Thank you for that.
Yeah. Now,
That's a
I
really
will say, going into social services, a lot of times, if we're not going in with a paper or something that's diagnosable, they will. Sometimes we have to fight to get in there as advocates. If I'm going into a housing office and I'm saying, hey, this person does have some difficulty understanding or reading some of these documents. I'm coming in as an advocate. They're speaking for themselves, but I just want to help facilitate the process and make sure they're understanding. Sometimes there is a little bit of resistance to allow an extra person into that space. And so we really need to fight to be able to make sure that they are able to have an advocate or supportive family member to get that extra support that they need.
Yeah, that's good. I want to kind of circle back to some things we discussed earlier. And when we're talking about empowerment, right? And then also now bringing in the youth to this conversation and having autonomy over your body. I specifically want to ask, how do you educate and destigmatize community members around birth control and other contraceptive measures?
So, I think there has been a lot of work around the stigma of birth control. When I first started, especially offering it to teens, it was like, oh, by offering choices, we're encouraging behavior. That was always, and even with HIV prevention, if we give them a choice, then they won't make the choice we want. So we really should steer them in the direction of what we think appropriate behavior should be. Um, and I think that more and more we're realizing the fallacy of that kind of thinking. Um, there's always a choice, and so someone will look at someone's life and say, oh, this is where you are, in terms of education, socioeconomic resources. Clearly, your decision should be this, and it's always your decision. It's always, and I may not agree with your decision, but it's also not my life. And so, informed consent at every level, whether we agree or whether we disagree, is important. And giving choices and really helping someone feel confident in their decision helps them kind of face outside judgment. I'm not going to be able to, education, we hope, changes some of the stigma, but really you just need to see a tide of more people standing in their decisions, and that is ultimately going to change minds. We know that previously, if there was a teen mom, the pregnant person was the person blamed for what was considered a poor decision, never their partner. We never looked at how old is this partner. Was this an equal relationship? Was there any coercion that was involved in coming into this pregnancy? We never looked at any of those factors. And I think that now more and more of us are realizing that it's a bigger issue, and that this doesn't exist with just one person. And so we need to address all aspects with the family.
Yeah, that's good. That's good. And I just want to reiterate a comment made by Ayana in the chat. Feel free to ask questions to Tahira. She has a wealth of knowledge, as you can see, and she's an expert in this field. So I see so many of you have joined in. Also, feel free to come off of mute and directly engage with Tahira. But we'd love to hear a little bit more about your perspective, your, I guess, response to some of the things. Maybe you've learned something that you didn't know before coming into this conversation. Maybe something confused you a little bit more, but please feel free to type some questions in the chat or come off of mute. I'll give it a minute to simmer before I jump in, but I'm super excited. So I just have like certain things bubbling.
Hi, everyone. I'm Lioness. I do have one question. This might be a little heavy, but we work in heavy, so we can deal in heavy. Have you ever come across a teen that has decided to, or that is pregnant, has decided to keep their child, but could have been possibly raped? They don't know who the child's father is, or could it be a father, an uncle, a family member that raped them, and they've decided to maintain and keep their pregnancy and gone through the process?
Yes. Yes, I have had that experience directly. And so in empowering, our first responsibility is to that birthing person and what they need. We are mandated reporters, and so we let people know that in the very beginning, that if the person is underage and this is clearly abuse and we see abuse, we have to report it. And we let them know that, and we try to create a safe space for open, honest communication and give them as many choices as they would like to have. But we let them know, like, these are things that we must report. And so let that inform the way you communicate, essentially, because they are our ultimate they're the ultimate person that we want to support and protect in the way that they want to be supported. And so we offer as many choices and resources as we can. We definitely want to create safety from anyone who will harm them. Sometimes, if they are making a conscious decision to protect someone who has committed statutory rape, essentially, someone who they know has committed a crime, and they are choosing to protect the identity of that person. If they haven't reported it to us, then we can't report it, but we know that there's a need to protect. And so then we create a safety plan to protect that person with the information that they give us. But if they've given us details that a crime has been committed, we do have to report and then move accordingly. But we're always giving choices in our safety plans, and that does include instances of statutory rape or incest.
So much.
Yeah, thank you. We have another question in the chat. What struggles have you encountered when working with birthers that have had FGM? FGM stands for female genital mutilation,
Yes.
for those of you who are not aware. And I'm excited to hear this answer because I've studied female genital mutilation heavily, but I've never considered what their birthing experience may look like. So I'm interested in hearing your response to this question.
So this is actually really interesting. It impacts pregnancy and the birth experience in a couple of ways. So I've had a few clients who've had, I had one client that had repair of FGM, and so depending on where you live or where it was where the act happened, there's a degree of cutting. Sometimes it may be just the clitoris. Sometimes it may be the clitoris and labia. Sometimes there may be stitching. So there are various degrees based on where it happened and cultural practices of damage that has happened. And so sometimes that's repaired. And that can impact a lot of things. That can impact your gait, the way you walk. And so that can impact your mobility and the birthing process, because you may have essentially it can create a disability in the fact that you have limited range of motion because of this practice. If there's a repair, sometimes in the birthing, in labor, that impacts the time of labor and navigating around scar tissue. So it can directly impact labor and pregnancy. And then, interestingly enough, afterwards, I had one client where it did cause some birth trauma for the baby. It caused some bruising on the baby's head. And it wasn't noted. It wasn't noted at the time of birth. And so when, because this person had given birth a few times before, and she said that it was an issue for her first birth, but then she had 5 other births that it wasn't an issue, and it just happened to be an issue because of the way she healed for that last birth, and it caused some bruising. And so when she went into the pediatrician to note the bruising, CPS was called. And CPS was called before they could confirm there was some bruising, and a simple scan could rule out shaken baby, rule out that the baby had fallen. But before that scan could happen, the hospital called CPS and a case was opened. And so by the time, and once it's open, they have to go through the process to just safely close it. And so it was really unnecessary, but it was traumatizing. And I was questioned about what I had experienced, what I had witnessed in home visits. And I was talking about how FGM could actually affect birth and cause that bruising. And that had not been noted. That communication had not been noted. And so sometimes not having consistent communication with providers. Her nurse, who happened to be from a country where they do practice FGM, noticed that this is a repair, but the midwife who delivered her didn't make a note of it. And so sometimes recognizing exactly what's happening and the impact and being familiar does impact the way they're treated and what the outcomes are. So yeah.
You know what? Thank you so much to the person that asked that question, because I also wanted to speak a little bit about what does culturally specific maternal health care look like.
Mhm.
And I think, like, when we talk about these unique experiences, like, we have to be well versed in what culturally specific maternal health care looks like. And so that's my first question. So it's like a two-part question. The
Sure.
two-part question is, what are some considerations for advocates who work for mainstream
Mhm.
mental health care organizations but service Black women? Like, what would be your advice to those, that population as well?
So it's interesting. Coming, and I knew this from a few other experiences. I've worked in spaces where people look like me but have had very different experiences. And I cannot assume, based on how you look or how you present, or, oh, we grew up in the same city, that you're going to have a similar cultural experience, that you have the same ideas, especially around your healthcare and birth. Some people, the first 40 days after they deliver is a sacred time, and they're not going to be outside. Like, there are a lot of things that culture impacts in terms of how you run your home, essentially. And taking the time to not make those assumptions, to listen and be open, for people to fill in the blanks about what their experiences are and what's important to them, is the best way to provide care in general. I think that we need to kind of shift the model of, like, oh, culturally sensitive care, and like, good care is culturally sensitive. It's not like, oh, I'm working with this specific population, so I need to do something different. We need to treat patients like individuals and be ready for them to tell us what they need instead of making assumptions. And sometimes we think, oh, this is going to be smooth. I know exactly what they need. And just by doing that, we've robbed them of the opportunity to get their needs met, because we're making assumptions and they're incorrect.
Yeah.
Um, And so, doing this work helps me see that a bit more, but I think that we all need to do it. And in working in a mainstream space, you never know who's going to walk through your door. And so just creating the space for dialogue, I think more space for dialogue will allow you to capture the stories of the people who are coming in, because despite initially thinking, oh, we're a homogenous group, you will, if you take the time to talk, you're going to see those differences and you're going to see a difference in needs.
Yeah, thank you. Thank you. We have a comment from Kaylin. She says, you mentioned medical rape. Sometimes a person doesn't feel like they have a voice to address this when it happens.
Yeah,
What
so.
steps would you recommend if someone experiences this? And then they go on to say, recently I received a serious report from my doctor and I started crying. My non-Black doctor said, you are a strong Black woman. That really pissed me off. I yelled, I am not, and you don't even know me. I can cry right now and not be strong. Is there a better way I could have handled this? So the first question was, what steps? Yeah, and let me know if you need me to repeat it. But
okay. So the first question is, what steps
would you recommend if someone experiences this?
Yes. Okay. So report it. Number one, people don't realize that a big part of all providers' grant money income is actually based on patient satisfaction. So your stories are important. And the only way to prevent this from happening again is to report it. So either you get patient satisfaction surveys, a lot of us throw those away or don't take the time. But that is actually something that they pay attention to because there's money attached to it. And so that is one of the places that you can start, is actually reporting it. If you've had the experience in the past, then really making that part of the conversation with your providers in the future. Like, this is the experience that I have had, where someone didn't talk to me about this, and I want to be really clear. Ask me before you touch me. Before we take this step, I want to be clear, and I want to make sure so that you're taking steps to kind of put it out there that you're aware of it, and that maybe they're not thinking of it, but that you're very much aware, and this should not be happening in the future. And so, what kind of exam are you giving me? You're asking me if you can do an exam. I am consenting to this. This is it. If you would like to do something else, then we need to discuss that. It's not just a, while you're here, let me throw in some extra things. Or, oh, I believe that this is the next step that's medically necessary. That needs to be part of a discussion. I can consent to that if it makes sense, but I need to be in a space where I can give my consent.
Yeah, that's good.
And certainly with the poor bedside manner of that doctor who thought that they were relating with the whole strong thing, and yeah, that is infuriating. Letting them know that doesn't work for me, and don't do that again. Like, I didn't appreciate that, and also don't do it to the person that comes behind me. That no, you absolutely, like, and not having to censor yourself, because that is the stress of weathering, of like, oh, how could I have handled that better? They were inappropriate and you responded and you reacted to something that was upsetting and traumatizing to you. You have every right to your reaction, to your response, and the way you feel. So that's number one. You have every right to that. Education can help with the next conversation. And if you feel like you need some support for the next conversation, that's fine. And maybe that can help the next conversation go in a way that you feel the most comfortable with. And so that's good, but you absolutely had the right to your response and your reaction.
Yeah. Absolutely. Ms. Henderson, I cannot thank you enough for the way you've engaged us in this conversation. It's been nothing but empowering, I feel so educated right now. It's been transformative for not just myself, but for many advocates that are on this call. And so I really hope that many of us have some great takeaways. And just to wrap up the conversation, what do you want to leave with the audience? Like, what are your hopes for birthing workers, and what do you think that Black maternal health care should look like in the future?
Yeah, that was a fun question too. So I think that greater collaboration, because like I said, this isn't just oh, this is my area. I focus on, maternal health. Maternal health is social support, it's family health, it's helping children, it's housing. There's so many ways that we can all support each other. And so strengthening those collaborations is ultimately going to make better outcomes for birthing people, better outcomes for families. And so like when our organization started 10 years ago, it was just two women who were working as doulas. And then it was like, hey, we need lactation consultants, we need nutritionists, we need advocates, we need mental health providers. And so the fight has become so much larger. And I think that we can all work together to strengthen our own causes, because they are intertwined. Domestic violence work is very much a maternal health issue, and vice versa. Housing, education, all of us can be working together. And so that is what that looks like. And also just I think that for people who provide direct services, one of the exciting things that I'm seeing is that our work is being captured in ways that it's leading to data in real time. So many of our stories were not being communicated when they're like, "Oh, what's the problem?" Like we know on the ground that the policies that they put in place weren't being implemented in the way that they're professing. And so that communication, and when people who look like us, who are in our communities, are saying, these are our experiences, what you may have intended is not what's happening to us. And that is going to lead to real time policy changes that are going to happen faster than than what we had been seeing in the past, where it's like, yeah, we all know that. We all knew that. We've known that for years. And now it's becoming a trending topic. So I think that that communication is huge. Those collaborations are huge, and that's kind of the future of maternal health.
That's good. I love that. I love that. And just reading some comments that are affirming you and bigging you up.
Oh,
But someone just, saying that this was empowering. Hannah says, Tahira, you are a huge wealth of knowledge. I'm so grateful. Asia says, thank you. This was informative. And Londa says, thank you. This was an informative meeting. And so I just really want to affirm you for being able to pivot from different topics in the Black maternal health space. It was awesome. Tahira, can you leave the people with your contact info so that they can speak further with you, or even if it's
sure,
just
absolutely.
some resources?
And I can just type this in the chat. So my email is tahira@mamatotovillage.org. But if you go to mamatotovillage.org, there is a whole staff of people that can answer your questions. And there are so many knowledgeable specialists in a wealth of areas. So anything that you need, we can find someone to answer those questions. Also, Mamatoto Village on all of the social media platforms. So I'll just put it in the chat. And if you have questions specifically for me, I'm happy to answer them. But if you'd like to just kind of peruse the site or the social media and get more involved with the organization, that would be wonderful too.
Yes, ma'am. Thank you so much. Thank you to our audience. You've been amazing. I hope that this conversation did what it needed to do for each and every one of you. Do not let this be the last conversation that you join in on. We have a month-long webinar series for DVAM, and so we hope to see you in the next coming weeks. Thank you all.